Great. So we'll go ahead and get started. And hello, and thank you all so much for joining us. My name is Megan Barasa, and I'm the program lead for the Micronutrient Data Innovation Alliance, or DINA for short. DINA is an alliance of diverse stakeholders working together to improve the availability, accessibility, and use of micronutrient data, especially to support national decision makers as they implement micronutrient policies and programs. Before we begin, I just wanted to let you all know that registration will open in the coming days for the Micronutrient Forum's 6th Global Conference on Nutrition for Resilience. This meeting will be a hybrid virtual and in-person event held from October 16th to 20th in The Hague. You can register soon and learn more about the event on our webpage, which will be mnforum2023.org, which will be put in the chat. So today's webinar is the third in a series of Hidden Hunger Coffee and Chai Chats. Back in October, the Micronutrient Forum and GAIN co-hosted a webinar that discussed the results and implications of the prevalence of micronutrient deficiencies in women and young children that was published in Lancet Global Health. We'll provide a link to that article in the chat as well if you'd like to go there and see the article. There's been so much interest in this first webinar and many topics that we could not cover in that one instance. So we've been hosting this special series of Hidden Hunger Coffee and Chai Chat webinars to discuss various other aspects of these new estimates of micronutrient deficiencies. Today, we have the pleasure of speaking with Dr. Ken Brown, who was the chair of the report's advisory panel, and we will discuss with him the micronutrient data gaps and how we can fill them. This coffee and chai chat format is really meant to be an interactive discussion with the participants on the call. So please be sure to engage with us and type your questions in the chat during the Q&A session. After Dr.'s presentation, I'll be calling on people to unmute themselves and ask the question themselves, or if you prefer, I can also read your question from the chat. Just let me know. And so now I would like to introduce our speaker. Dr. Ken Brown is an emeritus distinguished professor in the Department of Nutrition and Institute for Global Nutrition at the University of California, Davis. He completed his medical studies at the University of Pennsylvania and trained in pediatrics at the Boston Children's Hospital Medical Center. Dr. Brown has conducted research and published more than 350 articles on the causes, complications, treatment and prevention of childhood undernutrition in low-income countries. Many of these have focused on zinc, iron, and vitamin A micronutrient deficiencies. He has served as the founding director of the research unit in international and community nutrition at UC Davis, and the founding chair of the International Zinc Nutrition Consultative Group, as well as being a committee member on multiple global health organizations and technical expert groups, including that of the Micronutrient Forum. So I will now pass the screen over to Ken for his presentation.
Thanks, Megan. Greetings to all from not sunny California. We're all struggling to stay above water here. And I'd also like to make a special welcome to Judith Barasa, Megan's mom, who's joining us today. As Megan mentioned, my taking off point for today's presentation will be the publication by Gretchen Stevens and colleagues from GAIN and USAID Advancing Nutrition, in which they completed a set of analyses to determine or estimate the number of individuals globally who are affected by micronutrient deficiencies. So if I could have the next slide, please. I would like to start by saying a few words about that publication and the analyses that were completed, and use that then as a taking off point to discuss one of the critical limitations of the analyses, namely the sparsity of data on population micronutrient status. Now, first of all, I should mention that those of you who have been participating in these chats may have heard the presentation by Ty Beal, one of the co-authors of this publication, in which he presented a number of the results of the analyses. So I'm not going to go through those again today in detail. Rather, I would like to focus a bit on some of the methods and the importance of the analyses themselves. And then, as I just stated, use that as a basis for discussion of how we can do more to generate reliable information on population micronutrient status. Now, up to the time of this publication, we really did not have good information on the number of individuals affected by micronutrient deficiencies globally. One often sees in published papers a statement that more than 2 billion people are affected. But when you try to find the basis for that estimate, there really is not much information on which to base that, that statement. The publication that was tracked down as part of this set of analyses was a publication sponsored under the World Health Organization and was based simply on the prevalence of anemia globally. And based on those anemia data prior to the year 1990, an estimate was made of how many individuals were likely to be micronutrient deficient. And this estimate of 2 billion was offered. There are a number of flaws with that. First of all, it's hard to know exactly how the analyses were conducted because they're not very well described in the earlier documents. Secondly, we know that anemia does not represent the prevalence of all micronutrients. And of course, not all anemia is due to micronutrient deficiency. So one can question the basis of this analysis from the onset. How the Stevens paper addressed this issue was to examine data from nationally representative surveys for the period from 2005 to 2019, relying specifically on what were referred to sentinel micronutrients, that is, biomarkers of micronutrient status for those particular nutrients, namely iron, zinc, and vitamin A for children, and iron, zinc, and folate for women of reproductive age. They conducted a series of analyses based on the available data to develop global estimates using a set of, I believe, rigorous statistical methods and well-described approaches to the analysis so that they can be repeated by others who want to review the actual process of the analyses, and also can be used as a basis for future analyses to track trends in the number of affected individuals. Because of the limitations of available data, the analyses or the results that were published focused only on children less than 5 years of age and non-pregnant women of reproductive age. So there are a number of subgroups of the global population who are not represented in these analyses. Using this available information, the paper concludes that approximately 372 million preschool children are affected by one or more micronutrient deficiencies, and approximately 1.2 billion non-pregnant women of reproductive age. This represents more than half of all preschool children globally and more than 2/3 of all women of reproductive age. So clearly a massive problem, which may well be underestimated because of the missing subgroups and the missing micronutrients that were not assessed as part of this exercise. Next slide, please. I do want to highlight some of the strengths and also some of the limitations of this set of analyses. Strengths are that the research team relied only on data that was generated from representative population samples representing both national and subnational levels in countries with available information. The analyses were based strictly on well-recognized biomarkers of micronutrient status. As I mentioned, there was a series of rigorous and well-documented analyses to generate the estimates. And throughout this process, there were a series of independent external reviews conducted in part by the advisory panel that Megan referred to in her introductory remarks. And I'll say a few more words about the role of the advisory panel in a moment. The major value of these analyses is the fact that the information can be used for advocacy and several different types of advocacy, namely to carry the message about how frequent micronutrient deficiencies are on the global level and use that as a basis for arguing for the need for more control programs to reduce the prevalence of these deficiencies. And of course, given the issue of data sparsity, we can also use this information to advocate for the need for more data in countries that either don't have information on the prevalence of particular micronutrient deficiencies or in countries where the data are now outdated. Now, there are a number of limitations to the analyses, the most important of which, an issue that was highlighted by the authors themselves. So I'm not saying anything that the authors didn't recognize during the course of their work and throughout the publication, namely the limited number of countries that provided data for the analyses and therefore the need to extrapolate from the available data and assume that neighboring countries in the region had the same range of risk factors and likely prevalence of deficiency. And there was also an issue of data sparsity around a number of micronutrients that were simply not represented in many of the national surveys. Because of the limited data, the investigators concluded that they could not present prevalence data for individual micronutrient deficiencies. Rather, they focused on the number of individuals who are affected by one or more of these deficiencies. There are also several technical issues that were highlighted in the publication. The fact that sample collection and processing and laboratory methods were not standardized across surveys. So the compilation of data simply accepts by default the published results of the individual surveys. My conclusion from both the nature of the results that were presented and the limitations of the methods and the data are that the data can't really be used for program design, since programs require information on individual micronutrients or the prevalence of individual deficiencies in order to design the appropriate intervention to address those particular deficiencies. And likewise, the data are of limited use for program evaluation, again, because of the lack of specificity around individual nutrients. So I don't want these comments to undermine the importance of this work, which really is our first attempt and a valuable and valid attempt to assess the number of individuals affected by a deficiency. But we still need much more information on individual deficiencies from multiple countries and multiple nutrients in order to design appropriate control programs. Moving on from there, next slide, please. Oh, I did want to highlight briefly the members of the advisory council shown in the table on the right of this slide and thank them again for their participation in this process. The panel contributed in a number of ways to the analysis early on in the planning stages. The panel emphasized the desirability of focusing on biomarkers of micronutrient status, as opposed to the original plan to use both nutrient availability and national food supplies and dietary intake data to estimate the risk of inadequate intake and thereby the risk of deficiencies. Because of the lack of correlation of the dietary and food availability data with the nutritional status data, the panel argued that a focus on biomarkers would be a more rigorous approach to assessing the overall prevalence of affected individuals. And that decision was accepted by, or that recommendation, I should say, was accepted by the research team and was the basis of the analysis that was completed. The panel also assisted with a selection of sentinel micronutrients, the appropriate biomarkers to assess nutritional status for those nutrients, and the cutoffs that were applied to define deficiency. The panel also assisted with the identification of data sets that were used in the analysis. The panel reviewed the data analysis plan before it was actually implemented and helped review the results and interpretation of the analyses. So as I mentioned, there were multiple steps along the way where the panel met with the members of the research team and participated in this process. Next slide. Now, I'd like to spend the rest of my allotted time focusing on this issue of data sparsity and approaches that could be taken to increase the availability of reliable data on population micronutrient status. And to do so, I want to refer to a document that was prepared on behalf of the Micronutrient Forum and was actually published in 2021 called the Strategic Plan for Increasing the Availability and Utilization of Reliable Data on Population Micronutrient Status. The full report is available on the Micronutrient Forum's website, so you can download that if you want to get into some of the details of this plan. And a summary of the plan were also published in the American Journal of Clinical Nutrition in 2021. Next slide. I'd like to acknowledge the members of the core working group who were responsible for developing the strategic plan. The names of those individuals are listed here, along with several other co-authors shown below the table who assisted with the preparation of individual sections of the strategic plan. I should also mention that the draft plan developed by the core working group was circulated to what we referred to as the multi-stakeholder advisory committee. More than 30 individuals involved in implementation of national surveys, donor representatives who help support those surveys, and end users of those survey results so that they could provide feedback on the strategic plan, which was then modified and updated prior to its final publication. Next slide. One of the efforts that was carried out by the core group was to complete an analysis of the availability of data on the prevalence of specific micronutrients globally. And to do that, we reviewed information available on WHO's VMNIS website, the Vitamin Mineral Nutrition Information System, I believe is what the acronym stands for. On the website, you can find data beginning with the year 1950, and we were able to review data through, I believe, 2019, if I remember correctly. So nearly 70 years worth of information. And what we learned through that process, that only a small number of countries have actually produced information on a wide range of micronutrients. And if you look at the summary panel on the right of the slide, you can see that only 56% of countries produce any data on population, representative data on population vitamin A status over this 70-year period. 38% of countries provided information on biomarker of iron status, and even fewer presented data on folate, zinc, vitamin D, and vitamin B12 status. And only 1 or 2 countries had information on the prevalence of deficiencies like thiamine or riboflavin or other nutrients that are less well recognized as potentially problematic for public health. Not only are there relatively few countries and few nutrients that are represented in this WHO database, but as I say, these are surveys that were conducted over a period of 70 years, and many of them are outdated. And even countries that have attempted to update their information, there are relatively few countries, very few, that have conducted more than one survey over this interval of time. All this by way of re-emphasizing the fact that we really need better data, more data, and more reliable data on population micronutrient status. Next slide. To try to understand why more countries have not invested in generating the necessary information, individuals from IZINC, led by Mari Manger, did a series of interviews of decision makers and funders of surveys, decision makers in countries with regard to micronutrient programs or micronutrient surveys, as well as donor agencies that help support those surveys. And they identified a number of barriers and enablers of collecting this information. The main barrier that was emphasized repeatedly was the financial barrier. The country simply lacked sufficient funds to include biomarker assessment in national nutrition or other national surveys. They also identified a lack of knowledge or awareness of the importance of this information for identifying nutrient deficiencies and justifying the implementation of control programs. Other barriers that were highlighted were the lack of access to laboratories skilled in carrying out the necessary analyses and the cost of the laboratory analyses. And then there were a series of contextual issues specific to individual countries. For example, some countries don't permit biological specimens to be exported. In some cases, there was time pressure to complete surveys and insufficient time to actually develop a plan for including micronutrient biomarkers. And in some cases, a concern that the collection of biomarkers could interfere with the quality of other components of the survey. The interviews also identified a series of enabling factors that help countries make the decision to proceed with the data collection. Namely, when there were individuals within the government who understood the importance of this information and were able to advocate for the surveys within their own political context. This type of political advocacy can be aided by the presence of local champions, typically academicians, or in some cases, civil society organizations that argue on behalf of these surveys with the political authorities. The other two enablers that were identified were, one, the availability of local expertise, both for the survey design and the laboratory analyses that are required, and or expert to external technical experts who could provide that technical capacity. And finally, in some cases, the need for the survey information was based on the fact that countries had already launched an intervention program and were anxious to have data to judge whether the programs were successful or needed to be modified in any particular way. This paper has now been published, I think, late in 2022. So people who want to read more about these particular aspects of decision-making around micronutrient status surveys can access that paper. Next slide. Now, I want to highlight some of the conclusions of the core working group with regard to the analyses that were undertaken in developing the strategic plan. First, as I've said repeatedly now, that there is a limited amount of information available. We did note that the situation is changing and that countries that are conducting surveys more recently tend to include a greater number of micronutrients in the survey. There is much more information available now on appropriate biomarkers, and in general, the more recent surveys have taken advantage of that information and used appropriate biomarkers specific to individual micronutrient deficiencies. But again, we noted that relatively few countries are collecting the data. I think on an average, only 4 or 5 nationally representative surveys are conducted each year. And we need to at least double or triple that number if we're to have up-to-date information from the majority of countries globally. We also learned from these analyses that where data are available, that they do indeed contribute to program coherence, that they're used as the basis to justify initiation of programs, and in many cases, to modify those programs over time to ensure their safety and effectiveness and efficiency in terms of cost effectiveness of those programs. As I noted, there is good consensus on biomarkers. A number of expert groups have met over the past decade to publish their consensus opinions on which biomarkers to apply for which nutrients. And there are a couple of groups that I'll refer to at the end of my presentation that have been working to standardize laboratory methods that are used to measure these biomarkers. And finally, we noted another positive, namely that there are international groups that are archiving the information so that it is available for use both by individuals within countries as well as by the global nutrition community. And I refer specifically to WHO's database, the VMNIS, which houses results from national surveys. And I also mentioned the Brinda data set, which has the advantage of having individual level information on biomarkers of specific micronutrient deficiencies. And the final recommendation of that report was that we need a multi-component plan or set of activities to address this lack of information globally on a broad range of micronutrients. And there are 4 components of the strategy that were highlighted in the report, namely the need for more advocacy on behalf of the data collection and information dissemination on both the utility of the information and the methods that are needed to collect the necessary information, namely the survey design methods, as well as the laboratory methods for analysis of the nutritional biomarkers. A second component of the strategy is the need for financial and technical support for countries. As noted in my comments on barriers to data collection, far and away the most important barrier that was cited was the lack of financial resources. And also the lack of technical expertise on these particular issues of survey design, specimen collection and processing, laboratory analysis, and ultimately the data analysis and training and utilization of the information for policy formulation. The third strategic component that was suggested was support for the development of regional resource laboratories that would have a comprehensive capacity for analyzing the micronutrient status biomarkers that would participate in external quality assurance exercises, and that could also serve as training hubs so that individual countries can continue to develop that capacity. And finally, the report recommends that we need to invest more in data repositories so that the results of surveys are freely available to investigators and program planners and managers who need access to the information, ideally appropriately anonymized individual level data, which can provide for stronger types of statistical analyses. And also we argue for support to these archives or to academic groups drawing on these archives so that we could have more systematically periodic updates on the prevalence of deficiencies globally, risk factors that are contributing to those deficiencies, coverage of controlled programs, and effectiveness of those programs. Next slide. I wanted to highlight a couple of the suggestions of the working group that proved to be somewhat more controversial, or at least generate a lot of internal discussion and subsequently external discussion. And I mention these now because they may serve to stimulate some discussion during today's chat. First of all, there was a lot of debate about the need for national versus regional support laboratories to measure the individual nutritional biomarkers. In many cases, countries argue for the need to conduct these analyses in country and argue to the donor agencies that they need support for upgrading the national laboratory capacity before they can carry out a survey. Many in the working group argued that this was not a very cost-effective way of carrying out these analyses. What has been observed in countries is that they may gear up the laboratory capacity for an individual survey, and those laboratories go unused and for a period of years, in some cases forever, because they simply can't afford to maintain the laboratories. And we thought it would be more realistic to develop a regional capacity that individual countries could access rather than needing to develop this type of laboratory facility in every country. And as you can imagine, this has been a somewhat controversial statement, and I would love to hear individual opinions on this. We also argued for the need for a centralized funding mechanism because the amount of money that will be required to support the number of surveys that our group has argued for is likely more than any single donor is able to support. And so we would like to see a consortium of donors come together. We would like to see a more centralized funding mechanism that countries can draw on to help both with the design and implementation of national surveys, as well as with the related laboratory analysis. We thought that this funding mechanism should also provide support for the regional resource laboratories, both for analysis and training purposes. And finally, we argued that funding to individual countries should probably be conditional as a way of ensuring the quality of the information being generated in countries. And some of the conditions that have been discussed, and obviously this would ultimately be the decision of the donors and the countries themselves, but some of the conditions that were debated were the need for individual countries to provide some level of co-funding from national governmental resources in order to justify access to the central funding mechanism, that the countries would need to show that they're using appropriate biomarkers for the nutrients of concern in those particular countries, that they're using standardized consensus laboratory analysis methods if they're conducting the analyses in country, or they were accessing the regional resource laboratories for those analyses. And if the analyses are conducted in countries, one of the conditions would be that the national lab is participating in a global external quality assurance program. And finally, we argued for the need for countries to provide open access to the data once they have completed their initial analyses and interpretations at the national level. So again, I put all these items on the table to spur discussion among the group participating in today's chat. Next slide, please. I want to end with this slide. I had alluded to this in some of my earlier remarks, and that is that I wanted to call your attention to two groups that are currently active, mainly on the laboratory front, in trying to assist with both dissemination of information on laboratory analysis of nutrient biomarkers, as well as the development of a regional resource laboratory. So the first of these is a group referred to as Open Global, and you can see their website address on the slide here. This website provides information on a number of nutrition biomarkers, the related laboratory methods and quality control programs, as well as accredited laboratories that are conducting these analyses. And the website provides access to technical experts who can be consulted on particular questions that may arise related to these analyses. The other group is a collaboration between the Institute of Nutrition at Mahidol University in Bangkok, Thailand, and Harvard University, with support from the Rockefeller Foundation, which is working to build capacity in Thailand and in the Southeast Asian region for measuring key nutritional biomarkers, both micronutrients as well as nutritional biomarkers of chronic disease. And they are currently conducting a series of consultations with nutrient-specific and biomarker-specific working groups to develop a consensus on the best and actually a tier or hierarchy of laboratory and analytic methods that can be used for different nutritional biomarkers. And they're also in the process of compiling detailed laboratory protocols for conducting those analyses. In the upcoming years, this group plans to establish a model regional resource laboratory at Mahidol that will serve both as an example for what might be done at the regional level to provide this resource, and also make this laboratory available to countries in the region who want to draw on that expertise. So I encourage people to keep their eye on these activities if they would like more specific information on the laboratory analysis aspect of the data generation strategy. So let me finish there and turn the floor back over to Megan and invite all of you to offer your comments, questions, and discussion on these range of topics.
Yes, thank you so much for your presentation, Ken. I'm sure there will be questions coming. And I just also want to call people's attention to the chat box where my colleague Rajuta has been putting links to all the websites and reports that Ken has mentioned in his presentation. And also Monica from WHO has posted the link and information on the new VMNIS platform that has just been released. So you can see all of that information in the chat. So while we wait for some questions to come in, I just wanted to get the discussion started. And so as you mentioned a few times, Ken, and as I think most people in the audience would know, we do have a lack of sufficient data for micronutrient deficiencies. And so what are some of the risks of not having accurate and timely data on micronutrient status?
Well, I think the most important risk is the fact that an existing problem goes unrecognized. In many cases, these deficiencies, while subclinical, are still increasing the risk of adverse outcomes, birth defects, increased risk of infection, impaired growth of children, and impaired developmental cognitive capacities. Without the information on the existence of these deficiencies, and secondarily, the risk factors and the particular groups, most likely subgroups of the population likely to be affected, it's very difficult to justify the need for control programs and to design those programs appropriately to address those particular target groups. And I guess another aspect of this is once those programs are in place, we need continued surveillance, if you will, to understand whether they're actually effective in addressing the problem or whether they need to be modified in any particular way to be more effective and more cost effective. Speaking to the issue of cost effectiveness, what we see in many countries is that multiple control programs are implemented simultaneously, responding to different particular advocacy groups or different interested technical experts in country. And in some cases, what can be discovered through the course of these analyses is that there are redundancies in the program that essentially are wasting resources, or in some cases imposing a risk of excessive exposure to some of these interventions. And again, without appropriate data on the impact of these programs, it's really difficult, if not impossible, to assess that set of issues. So the whole range of reasons why the data are extremely useful, as I say, both for advocacy as well as for program design and monitoring.
Okay. So I see we have a couple of hands up. So in the interest of time, I'll go to them. Mesfin, please go ahead. If you're able to unmute yourself. Yeah. You can
Okay. Thank you, Dr. Brown, for the presentation, and thank you, Megan. My question is, biomarkers, as you said, are the gold standard to estimate micronutrient status. However, I mean, there are a number of barriers, including the need for high-tech laboratories, which I've mentioned, and also like the invasiveness with the procedures, and some other local regulations actually forbid, I mean, the use of these, biomarkers. So, my question is, do you have other proxy indicators that are considered by the group or by the international experts, for use by international development organizations, like my own, I'm working for Catholic Relief Services, which we can use for monitoring of, any project impact. So, do you have, recommendations for those like proxy indicators? Thank you.
Yeah. It's a good question and a difficult one, and one that, as you can imagine, is hotly debated. And I represent perhaps one extreme in the range of opinions on the matter, in that I have continued to argue for the importance of the biomarker information, as you indicated, as the gold standard for nutritional status. We can talk about a hierarchy of information, starting with nutrient availability in national food supplies, being very careful in how we interpret the information. If there simply is a lack of adequate supply of nutrients in a particular country, one could predict that there is likely to be, almost certainly going to be, inadequate intake of that nutrient and secondary deficiency. On the flip side of that, though, is not necessarily the case. That is, the food supply may appear to be adequate, but because of inequities in the distribution of individual foods or nutrients in the food supply, even though the food supply appears to be sufficient, there may be many individuals with inadequate intake and deficient status. So I argue that the food supply data can be used to highlight the need for more specific information on dietary intake or nutritional status, but should not be used alone to make statements on the prevalence of particular deficiencies. Secondly, we have a range of information on dietary intake, and again, of varying quality, depending on how the dietary data are collected and analyzed, and the availability of local food composition tables that allow for the conversion of food intake to nutrient intake. But again, recognizing that adequacy or inadequacy of dietary intake of a particular nutrient does not necessarily equate to deficiency or lack of deficiency for a whole range of reasons, including variations in genetic requirements for a particular nutrient, absorption of that nutrient because of underlying intestinal dysfunction, and the fact that certain nutrients can be stored for long periods of time in the body. So even if the dietary data suggest a current inadequacy in intake, that doesn't necessarily mean that an individual is going to be deficient if they had adequate intake at some prior point in time. So there are a whole series of reasons why the dietary data may not be entirely reliable in terms of predicting micronutrient status. Now, having said that, there are a number of groups that are active currently using, big data, if you will, trying to identify, are there particular risk factors that are useful predictors of micronutrient deficiencies. I personally am skeptical about how successful those approaches are going to be, but it certainly is something worth pursuing for all of the reasons that you mentioned in terms of challenges with generating the micronutrient biomarker information. And I'd like to finish with just making one statement referring to work that our group through the Minimod team has done in Cameroon and subsequently in other countries, namely putting together data on both micronutrient intake and micronutrient status, as well as the cost of intervention programs that are designed to control those deficiencies in the affected subgroups of the population. And what we learned in Cameroon was because of this is particularly with respect to vitamin A intervention programs, which in Cameroon were based on periodic large dose vitamin A supplementation and fortification of edible oils and periodic distribution of micronutrient powders in some subsets of the population. And what we did was to cost out those different interventions. And we learned that in some cases they weren't well designed, that we were fortifying foods that were not consumed, for example, by the high-risk subset of the population, or that we were delivering large dose supplements in segments of the population that were not at particularly high risk, and that those periodic campaigns are particularly expensive. So what we learned by having all these different sources of information was that we could model a more cost-effective program, which over the course of a 10-year time span, we estimated could save the national government $18 million in expenditures for unnecessary programs that were currently being implemented. It cost us just over $1 million to carry out the survey and all the related analysis and modeling to come up with those conclusions. So the bottom line is that, yes, the survey work was expensive. We had to invest over $1 million to generate the information. But by having the information, we could help design programs that had the potential to save $18 million over a 10-year time span. So again, trying to make the case that although the data are expensive, and in fact, in many cases, they can be used as a cost-saving exercise. And you need to keep that in mind when you focus on the cost of the data collection.
So we have just a few minutes left. I want to get to Kevin's question, and then I'll take one from the chat. So Kevin, go ahead.
Hello. Hi, my name's Kevin. I'm from WFP. Thanks so much for your talk. I was wondering, how much do you think, or how important do you think it is to further invest in understanding the relationship between inadequate micronutrient intake and the subsequent deficiencies? Or do you think it's worthwhile to invest in other kinds of data or other methods to understand potential risk factors leading up to deficiencies?
Yeah, thanks, Kevin. I have met you a couple of times now, I believe, through discussions with the MAPS team. So thanks for participating today. I don't want my comments to be interpreted as any statement on lack of importance of collecting dietary data. To the contrary, I think the dietary data are equally important for a whole range of reasons, including understanding which foods are major sources of particular nutrients in a given setting, so that we can encourage the food system to provide adequate nutrients through the food supply. And if we're talking about specific interventions like food fortification, we need to have information on consumption of potential vehicles for fortification. So there are a number of other reasons or additional reasons why the dietary data are extremely valuable. And I don't mean to undermine the importance of that information. Because I would argue that we need both dietary data and biomarker data, it does provide the opportunity to continue to understand the relationship between intake and status in particular settings, and what are the modifying effects that we need to understand in order to be able to use the dietary data alone to predict the risk of deficiency. So I would encourage continuing to invest in both sources of information.
All right, I'll go to one last question from the chat, and this one comes from Jonathan Gorstein. And he says, in addition to household-based surveys and setting up regional labs, what is the role of rapid field-based diagnostics to measure biomarkers and leveraging our existing surveillance platforms to access panels of individuals to collect biological specimens that can generate more data on micronutrient status on a more routine basis?
Yeah, thanks, Jonathan. As you well know, we have invested in efforts to develop analytic capacities, as well as multiplex systems to try to facilitate the laboratory analysis. I'm going to answer your question in a couple of different ways. First, I want to focus on the survey data, which was really the primary focus of my presentation today, and the need for nationally representative information and ideally subnationally representative information periodically. And I would say every 5 to 10 years is probably adequate to help guide programmatic activities. For those types of surveys, I don't see any particular advantage of the point of care diagnostic capacity. The reason being that there are still some some biomarkers that are simply not going to be analyzable at point of care. And that means we would still need to have a capacity to move those specimens from the field to the central laboratory for analysis. And as long as we have to do that for any analyte, there's no particular advantage to completing other analyses in the field if we're moving specimens to the laboratory in any case. So that's one issue. Another issue is where we are in the development of those methods and which particular biomarkers can currently be analyzed through a point of care device, and how well have they been validated. You know, I think there are a number of reasons that it would be useful to have that information, more so for clinical care, I would say, than for population assessment. But in any case, it would be useful to have those point of care, that point of care capacity. But we should only accept those results when we're confident that they have been fully validated against standard laboratory tests, and that they are continuously monitored with regard to their external quality assurance. And my reading of the current literature is that we're not quite there yet. And I don't know how many more years might be necessary until we are there. And even at that point, as I say, I think we will be able to do that for a limited number of micronutrient biomarkers. I don't know at what point in time we'll be able to cover the full range of biomarkers that we would like to have for planning our public health programs. So a mixed response. I see some benefits and some aspects of that approach that aren't necessarily ready for prime time, if you will.
Great, thank you so much. So I think that puts us just about at time. So I'd really like to thank you, Ken, for joining us and for all of our participants today. It's been really great to have all of you here. And so I'll just conclude with a few words. As we've seen from Ken's presentation and our discussion, that micronutrient data is vital to developing and monitoring safe, effective, affordable strategies for micronutrient deficiencies. And from some of the conclusions of the report he presented, we know that we need to do more to better advocate for data and disseminate the information that we do have. And we need to also support countries both technically and financially to do surveys, perform the analyses, and to make sure that the data get used. And having greater laboratory capacity with external quality control will be helpful in this, as well as training people to be able to analyze the specimens. And then we also need ways to share the data as much as possible, such as through the WHO's platform. So filling these data gaps and advocating for collection, analysis, and use of data is one of the key missions of DINA. So if you'd like to learn more about us, please visit our website and sign up for our newsletter and consider becoming a member. Over the next few years, we'll have several opportunities to engage with members to help support and strengthen the micronutrient data ecosystem. Please stay tuned for information on our next Hidden Hunger Coffee and Chai Chat that will be happening in February, and we hope to see you all then. And thank you again for joining us.